First of all, we're just going to briefly look at, what sexual assault is. And you probably already know this, but it's any sexual contact that happens without your consent. So again, the myths would tend to perpetuate that this is rape, this is penile vaginal penetration. And actually sexual assault is a spectrum, and it includes, groping, kissing, any unwanted sexual attention that you haven't actively consented to. And I think for us, understanding what that looks like, what that spectrum looks like, is important, because a lot of people, especially a lot of young people that I see, actually don't understand what consent looks like and don't understand that consent is an active process. It's something that can change actually from one minute to the next. It can change within a relationship. You consent to having all sorts of sexual activity with someone one day, doesn't mean the same thing is going to happen the next day with your consent. So I think it's really important that we understand that, partly in our roles as health providers, but actually as parents and family members as well. And you cannot consent if you are really intoxicated, under the influence of drugs, if you have acute mental illness such as psychosis. A lot of people with IHC and developmental delay will not be of a developmental age where they are able to consent, even though they may be adults. Sexual assault, as we've talked about this morning, often occurs in the setting of IPV. So if you're seeing one, think about the other. And although we know there are groups that are more vulnerable, and that especially includes young women. A lot of the workload through our services would be, young girls and young women sort of between the ages of 15 and 23, 24. But actually any age, any gender identity, any sexuality, any ethnicity, any background can be affected by sexual assault. And I apologise in advance for often talking about she when we're talking about the impacts, because it absolutely isn't the case that it is only, people who identify as female that are the victims. But because they're the sort of more common group we see, we tend to talk from that point of view. So the epidemiology, it would be safe to say that I think collecting data on this is really, really difficult. So statistics and prevalence information and stuff is, often will have quite wide ranges, and we don't really know. We've looked at doing this at university where I work, and it's a really hard thing for lots and lots of different reasons. But what we tend to talk to is that between 1 in 3 and 1 in 5 women, between 1 in 4 and 1 in 20 men, and we really don't know, I think, in that group, and higher rates amongst those that would identify as trans are the rates in New Zealand as far as we know. Up to 1 in 3 girls will experience unwanted sexual experience by the age of 16. Now that is not all going to be rape, but that is going to be some type of unwanted sexual experience, and 1 in 5 women will experience sexual assault as an adult. These are the rates for Australia down the bottom here, and again, it's difficult data to collect, so you'll often see quite different figures quoted, but I think everyone would say the same thing. This is prevalent, really prevalent, especially amongst younger people. This is a study that was published in The Lancet, and these two things here are really the interesting things to me. This is the person responsible at the most recent occurrence, and again, that's the thing around those myths that this is going to be a stranger. And if we approach it assuming that that's the setting that sexual assault happens in, we're going to miss the vast majority of them, because actually, as you can see, in nearly all situations, it's someone that's known to them, a current or former partner, a family member, or a just met acquaintance. A stranger sexual assault is much, much rarer. And this is the median age at the most recent occurrence of non-consensual sex. So again, very young, and that would be backed up by the people we see coming through the clinic. So obviously there's lots and lots of impacts of any kind of trauma. When we're looking at sexual assault, these are the psychological impacts. And for me, I'll let you read the slide because it's a little bit wordy, but I think over the years that I have been seeing people in this situation, either acutely or when they've come in and disclosed a historical event, one of the things that really strikes me about it is the top one, the profound disempowerment. And my understanding of this from having talked to lots of these people is that, when you're sexually assaulted, someone has taken control and power from you of a very intimate part of your body, and there was nothing that you could do about it. And that seems to be one of the most impacting things for people. And I think the good thing about understanding that is that actually we can start to put that right from the minute they come in to see us. So the minute someone walks through the door of our service, the sexual assault service, whether it is the nurse or myself or the support worker that we have working alongside us, it's all about handing that back to them. So saying from the very first moment, what happens from now is up to you. You know, as long as I don't have concerns about your safety, everything else is going to be your choice. So you get to choose whether or not you want the police involved. You know, you get to choose if you want the support worker to sit in while we talk about what happened or whether you want them to wait outside. When we come to the examination, you get to choose if you want me to do a genital examination or not. And if you don't want me to, there's absolutely no way that is something we would do without your consent. And I think that in itself is a way we can all start someone's journey of recovery. And actually that's why doing this work, although I guess when I started out I thought, gosh, this must be a really traumatic experience for victims to come in and see a doctor when you've just been sexually assaulted. Actually, I think universally they find it a really positive thing to have done. And that's because they're taking a little bit of that control and power back over their bodies, and they are deciding what happens next. So when you see someone and they've disclosed or you've asked them the question, that's a really easy thing to do, is just to say, okay, here's some choices, you know, and of course you need to make sure that that's safe, but actually doing them, you know, giving that to them, you know, that power back is a really, really important thing. Then there are obviously physical impacts as well. So as well as the psychological side of things, you know, someone who has been sexually assaulted may be injured. We'll talk a little bit later on about rates of injuries, but they're pretty low. Genital injuries in after an acute sexual assault with penetration are thought to be round about 30%. So, you know, the most people that we see will not have any genital findings. That rate is slightly higher amongst women who have had the menopause, because obviously their genital tissues are a lot less robust and a lot more likely to be fragile, and also again in people pre-puberty, because again those genital tissues are not estrogenized and they're not nice and stretchy. In terms of extragenital injuries, especially common in the setting of intimate partner violence, as Claire talked about, but we do see it in other situations as well. You know, it's not uncommon for us to have, for example, you know, an internet dating scenario where someone eventually meets the person and they will go and there'll be a very violent sexual assault with a physical assault as well. So we probably see, you know, more physical injuries than we actually might genital injuries. We obviously need to be considering sexually transmitted infections, as much at risk as you would be through any other sexual contact, and any chance of pregnancy. So these are all some of the sequelae, the physical sequelae that can happen from sexual assault. The longer term stuff Claire talked about briefly in the intimate partner violence one as well, but these are really interesting to me, you know, that some of the chronic pelvic pains we see, the dyspareunias, the vaginismus, the non-specific vaginitis, even people with chronic pain in other parts of their body, migraines that you just can't get on top of, irritable bowel, all of these symptoms that come into general practice again and again and again. And you think, I've tried everything. I've been down every pathway, I've tried everything BPAC recommends, and they're not getting better and their symptoms aren't being controlled. Always think about asking the question. And whenever that has occurred to me, and I've done it, the rate of disclosure actually is astounding. And that's probably because you've already been seeing them for a few months and there's a certain degree of trust there. But it is really important when you're seeing these patients to think, is there something else underlying it? Because if you keep chucking medication at it and you're not getting anywhere, the chances are there's something bigger than that going on for them. And it can be such a relief when they say, oh, actually there was, and then they can make the link that maybe that's where their symptoms have come from, and they can stop taking pain relief or whatever else you've put them on because there's something else that they need to deal with that might help. If someone you're seeing has those symptoms, always think to ask the question. Secondary victimisation. So as well as the physical and the psychological effects that can happen at the time, there are secondary effects that can happen as well, and these can occur, sadly, through the responses of individuals and institutions and people in the community around what has happened to that person. And examples I can think of are, you know, we had a young woman that came through our service who was horribly raped by a group of young men as part of a gang initiation. She was 15 and they were all 18. She went back to school and she told a couple of friends that this had happened to her, and she was deeply traumatised, and I think she just needed some support. They immediately said, we don't believe you, we know those boys, they wouldn't have done this. She ended up friendless. moving schools, dropping out of school eventually a year later, actually having already been through this terrible, terrible trauma. And that's secondary victimisation. And really kind of working as a community and as a society as to how we deal with this stuff is really, really important. It includes victim blaming, inappropriate behaviour or language. From our point of view, we can minimise that by how we approach this from the time of disclosure. So it's really important that when someone tells you something has happened to them, that the first thing you say is, were you drinking? Or were you at a party? Or, that anything that implies that somehow they were responsible for this. Of course, those are pieces of information that we may need to know, but how you frame that and when you ask them that is something they're going to take with them. You can ask that well, and they'll go, well, that was just part of the routine inquiry that doctor had to know, or they will leave thinking, oh my God, this was my fault because I went out on Courtney Place and I had a few drinks and I shouldn't have done it and this is what happened to me. And that may never leave them, that feeling at that moment. So being really careful not to judge and to phrase what you say in such a way that they know there's no blame attached to them is really important. And Claire mentioned this briefly as well. There was a study that the Ministry of Women's Affairs did a few years ago called Lightning Does Strike Twice. And it looked at, if you had been sexually assaulted once, whether you were more likely to be sexually assaulted again, and you were. And I think there's a whole lot of reasons around that. One is that if you have been the victim of a sexual assault ever, you're more likely to partake in risky behaviours in the future. So that may be self-medicating through alcohol and drugs or self-medicating through sexual behaviours. Reasonably often we will see young women who have been sexually assaulted and then go out and seek lots of casual partners because it's a way of kind of, I guess, forgetting that what has happened to them. And then you're going to be in a more risky situation. I also think probably for some of these people, it alters the way they pick up danger signals. So they may be in a bar and there may be someone that is quite clearly grooming them for something and they may not pick that up, whereas the person next to them may have done. So there are lots of reasons why it happens, but from our point of view, what it means is that when someone comes into you, either as a GP or a nurse or a midwife or in our roles, they're not necessarily just bringing that episode of trauma with them. They may actually be carrying a whole lot of baggage from stuff that happened years and years ago. And acknowledging that and gently asking them about that. You don't have to solve that for them there and then, but people will often have a whole lot more trauma than you could ever imagine. So early intervention is really important to try and minimise the impact, and I guess that is all of our roles. If you get a disclosure and someone tells you that they have been recently sexually assaulted, wrapping around specialist support and help for them as quickly as you can is a really good way to make sure they get the absolute best care. And that is exactly the same as if we were seeing someone with a head injury or a nasty fractured shoulder. We wouldn't think, God, I've got to know how to deal with all this myself. We'd go, okay, what I need to know is how to refer to the people that deal with this all the time, that know how to approach it and know who else to contact. So that's probably all you need to know from today is how to contact those people. And they would involve the crisis support worker. And in Wellington, we're really, really lucky. Our agency will be coming later on for the panel discussion. And they attend every sexual assault case that we do, actually. And we don't really kind of offer it as an option. We just say, this person's part of our team. They're here to support you. It's your choice whether you want to talk to them or not. You absolutely don't have to, but they're sitting here. They're for you. They'll stay for the duration of the case, and you can catch up with them after, or they can call you tomorrow. And without fail, people, of course, do want to have a conversation with them and do engage. But they're a really crucial part of our team. I would really encourage that you get your local forensic SAT service involved, who are the Sexual Assault Assessment and Treatment Service, and I'll show you in a little while how to find out who that is in your area. They are doctors and nurses who deal with this stuff a lot, and they would know exactly the kind of processes to follow in your area. So if you've got someone that has had a recent sexual assault, ring that service, pick up the phone and ask for advice. Even if they say, actually, this has been 2 weeks, we probably don't need to see them tonight, they will be very happy to give you advice and advise you on that. Prevention of STI and pregnancy is important, and that's something that the forensic team will do if they see that patient for you. And also toxicology, and I've put in inverted commas, proof of what happened, because a lot of people will come to you saying, I don't remember what happened, but I want to know. I want to know if someone had sex with me while I was passed out last night. I feel like they have. And that's actually a really, really common story that we get through the sexual assault service. Now, obviously, we can't, unfortunately, always tell them. So it's important that if that's what they're wanting from us, that you're actually honest about that and say, look, there are occasions where the doctor will be able to tell you. You know, sometimes we can look at a slide and find semen and tell you that something's happened, but more often than not, we can't. More often than not, there won't be injuries. We won't find anything to tell us either way what has happened, but we can talk them through the process of what they can do about things. We would encourage people, if they're ready, to initiate counselling early, and obviously when people are ready can vary from immediately to months and years down the track, and some people will never be ready, and that's okay, but ensuring that they know where to go when they are ready and when it's the right time for them is really, really important. There is, unfortunately, in lots of parts of the country, a really big wait for ACC counselling. I know that ACC are working incredibly hard at looking at different ways of delivering their counselling packages so that that bottleneck can be reduced. But it is hard, and I think what often happens is that those patients end up then being held by either GPs or other counsellors, or, as I know, our student counselling service has masses of these patients who are waiting to get into a specialist sexual assault counselling service and there isn't room. So it's not ideal, but I think if you can encourage someone to go, it's still really, really worthwhile. Appropriate medication if needed. So if someone is not going to come to our service and they're seeing you, you do need to be thinking about, do they need emergency contraception? Do they need STI prophylaxis or treatment? And addressing any physical and medico-legal issues early as well. So thinking about injury. This was a sexual assault, that's what they've told you about, but actually you need to ask, was there a strangulation? Was there a physical assault as well? And if there was, deal with that as you would in any other therapeutic setting. Medico-legally, that's around the documentation that Claire talked about before. So how do we encourage disclosure and therefore enable early intervention for all of these things? So what I want you to do now is think about, and if you're brave, stick your hand up. How does it feel to have your piece of information in here? Anxiety-provoking. Anxiety-provoking, yep. Spooky.
Who else is going to see that?
Who else is going to see it? Yep.
Definitely didn't reveal the worst thing, just a little bit.
Yeah, a little bit of the worst thing. So you half revealed.
Vulnerable.
Anyone else?
Very vulnerable.
Very vulnerable. Yeah. Shamed.
Guilty.
Guilty.
There was no way that I was going to do it until you said you can screw it up.
Yeah. Okay. Yep. Yep.
There's no way I was going to
Yep.
write anything.
Yep. Fair enough.
I don't feel too bothered because everyone else has written something and no one will know which one's mine.
Yep.
And I know you're not going to be born.
What are you fearful I might do with them?
Read them out.
Read them out.
Just a self-depreciation of how, ashamed I feel anyway. So I suppose it's really just a real personal thing, is it,
Yep. Yep. When I did this with the GP students yesterday, someone thought I was going to match up, go around the room going, this is yours. And look, they're going to be instantly shredded. No one will ever open this envelope, okay? Rest assured. But the reason for doing this is because every single time we ask a patient to give us personal information, that's the situation they're in. People will feel ashamed, vulnerable, scared. What on earth is this doctor or nurse going to do with this information? What are they going to do? Who else are they going to tell? Are they going to laugh at me or say, oh, this isn't your story's this? And there's a whole lot of things that go through people's heads when we disclose, and it's a massive, massive thing. It's a massive thing for me to have asked you to do, so thank you, because it is about trust. So it's a massive thing when we ask our patients. And I think expecting people to always be honest is probably the first thing that we shouldn't do, because it is really, really, really hard. People might give us part of a story, and that's absolutely fine. But also saying, I know how hard this is. You can say, I've done this in a workshop full of 35 people. But, knowing how hard it is and acknowledging that and instantly assuring them that actually you're doing this because you want to help and support them. You cannot guarantee them that you're not going to have to tell someone else, but you can guarantee them that you won't do that without talking to them. And you'll give them choices about, who do we need to speak to about this? These are the options. But I think remembering how this feels at this moment, to have this information sitting here, is a really big thing to take with you actually when you're sitting in front of a patient. And I do that, and I did this once in a big conference, and I felt completely overwhelmed actually by how vulnerable I felt. And I suddenly thought, oh my God, I do this every day I go to the sexual assault service. I sit down and say, okay, tell me about the trauma that's just happened. And then I say, tell me about who else you've slept with in the last week and what drugs you've taken, and all of this stuff that I expect them to tell me. And it's absolutely huge. So I think just remembering how that feels is really helpful when it comes to how we deal with this stuff. And I promise you that will be shredded. So think through the barriers to disclosure. Why do people not just present at their general practice the day they've been sexually assaulted or the police and say, this is what's happened to me? So there's heaps and heaps of different reasons, and fear is probably top of the list. They're really fearful that no one is going to believe them. Why would someone believe them? They might be 15, they might never have had to go to a doctor on their own before, they might not have the words to tell you exactly in grown-up language what's happened to them. They'll be really fearful about that. They're going to be fearful that they're going to be judged. So you can say that straight away. I'm not going to judge you. This happens to lots of people. It's awful. Thank you for telling. Thank you for sharing with me. Recrimination for them and for the assailant. Interestingly, when people are sexually assaulted by someone they know, whether it's a friend or a partner or a family member, as Claire said, they will often have a lot of affection and real love for that person. So although they know that it's wrong, that doesn't mean they want recrimination and they want the justice system to kick in. So they'll be weighing all that up in their heads. What happens if I tell, suddenly do the police turn up on his door and drag him off to prison? Because they won't necessarily understand the system. There's one young woman that I saw who illustrates this really well, and she was 15 and she came through the police, and they kind of came in a little bit rolling their eyes saying, she says 4 men in balaclavas turned up on her door in Porora and dragged her through the bushes and raped her, and she managed to escape. And so I sat down with her and I thought, right, we're going to have a really long time. I'm going to go really, really slowly with this young woman. And over the course of the next kind of 30, 40 minutes of questioning, I was thinking, this story's changing a bit. I don't think this is exactly what happened to her, but she's clearly very, very shocked and traumatised. So at the end, when we'd examined her and actually the injuries didn't fit with what she'd said and it wasn't all quite holding true, I said, look, I know that something awful has happened to you. I know that, and how brave you are coming here and getting help. That is huge. But I do think it wasn't the way you've told it. Do you think you can tell me if there's something else that happened? And it turned out that she had been sent from Samoa by her mum to live with her aunt and uncle 3 years before, and within a week of arriving, the aunt had started really badly physically abusing her every day after school, and she was kind of kept a bit like their servant in the house, and then she'd have to go to school, come home, do all the housework, make all the meals, be beaten very regularly. And then a year after that, the uncle had started sexually abusing her. And she still loved them, and she still felt really grateful that they had given her this opportunity at education that she might not have had back in Survey. And so she didn't want to name them. She wanted to get out, and she wanted help, and she wanted someone to be able to support her, but she couldn't bring herself to say who it was because of fear of recrimination and affection for them and a whole lot of other, loyalty and family ties. So it's really easy, once you think about stories like that, to think, I get why people might not come and say this, or they might not tell me exactly what's happened. And if we look at stories that might not be quite the way they actually happened, I think the police call that a false allegation. I don't know about you, Claire, but I have almost never actually seen a true false allegation that's come to our service and has gone through a forensic medical examination. But they often may be this, where actually what they've told you is a different version of some other kind of trauma. So it's very rare for someone to come and go through a forensic medical examination and then go, nothing happened, because why would you? But actually, there's often another version of what has happened that's going on. People are often quite shocked and in a state of disbelief. We will often see people, very quickly after a sexual assault, if, for example, they've gone and told a friend, and they'll bring them in quite rapidly to the police and then to us. And the patient themselves may be absolutely, I have no idea how this happened. This is my boyfriend or someone I know or someone I just met, and the next minute I'm here in a sexual assault clinic being seen by a doctor. So there really is hard for them to understand what's happened. So sometimes if they haven't told anyone, that can take days and weeks to unfold and them to kind of start believing it and then go, okay, do I want to do something about it? They may not know where to go at all. I think now we have a bit more visibility about the different options after a sexual assault. But early on, I think people really thought the only place to go was the police. And for a lot of the people we see, the police have not been a good influence in their lives. They may have been a family that has had lots of police involvement that has not been positive. So the idea of going to the police for help and support is really alien to them. So they don't know who else to tell. So hopefully now that is getting better. There are lots of kind of visible platforms now where you can go and Google and it will lead you to the right places, but that's relatively recent actually. So prior to that it was really hard to know where to go, which is why they will often go to their primary care health provider, because you've always been seen as someone that will offer health advice, support, guidance, and kind of an open door really for anything. So I think it's really easy to understand why people will often go to their GP or nurse in the first instance. They may have a really poor memory of events, and that's especially the case after either an alcohol-assisted sexual assault or a drug-assisted sexual assault, where someone is passed out, unconscious, got very patchy recollection of what's happened. They wake up saying, I know that someone's had sex with me, or I've woken up in someone's flat that I don't know without my trousers and pants on. I don't know what's happened. So it's very hard for that person to think, I should go and get help, because they actually don't know what's happened at all. So we see a lot of those, and sometimes that can take weeks to kind of unfold a little bit of memory. They may get patchy recall, they may get none at all. And that can actually be really distressing, not know, kind of knowing that something's happened, but not knowing what it is. They may not know how to frame it, and that's that cup of tea thing, that for a lot of people, sexual assault is, rape by a stranger in a dark alley, and they will not understand that if their partner has forced them or coerced them, or someone they met at a party and were flirting with and kissing with, and it was all on, and then suddenly actually they felt a bit scared and didn't want to, that too is sexual assault. And I've had people at university who have come and disclosed, at the age of 18 or 19, something that happened to them at 15, and it's only when they come to uni and they see we do a lot of advertising campaigns around this stuff, or they go into a criminology class and learn about it, or they talk to a friend who's been through a similar experience and go, actually, oh my God, that's what that was, and that's why it has felt so hard ever since. And they may not want to do anything about it, but it's actually quite helpful for them to understand why it didn't feel right. And then the last one is a real biggie, self-blame. I think almost every person I have ever seen through the sexual assault service on some level blames themselves for what happened. And again, as well as handing them back the power and control, I think a part of what we can all do therapeutically is to say, you were not at fault. This was not your fault. No one should ever, ever do that to anyone, no matter how drunk you were, or what party you were at, or what you were wearing, or what signals you gave them. It does not matter. And I think you can see people kind of visibly take that on board actually when you say it. So try and remember to actually positively put that out there. You may be thinking it, but actually tell them. One of the things we get a lot, which I find really difficult, is the conversation around alcohol, because a lot of sexual assaults, as in that Who Are You video, happen in the context of a lot of drinking. And if it's a young woman, she will often say, look, I was really pissed, and I know if I hadn't been, it wouldn't have happened. And I really struggle with how to have that conversation, because alcohol is a risk. But you want to acknowledge that, hopefully at some stage modify the drinking behaviour of our culture, but not put the blame at their feet as the person that had been drinking. And something I sometimes say is, look, if you walked down Courtney Place or wherever the equivalents are in your town on a Saturday night and there was a young man lying in the middle of the pavement so pissed that he was passed out, what would you do? And they always say, oh, well, I'd either just walk past if I was with my friends, or I might call someone, or I might check that he was alive, or call the police or whatever. And I say, so you wouldn't, kick him in the head, take his cell phone and his wallet and then leave him there? And then, no. So I was like, okay, so actually that's the equivalent of what has happened to you. You were vulnerable, you were intoxicated, and someone has done a terrible thing to you in that situation. So don't own it. It is not theirs to carry that blame into the future. So if you do, or you are in a situation where you get a disclosure, this is going to be one of the most important parts that you play, is how you do this and how you do this well. And this is going to actually probably replicate a lot of what Claire talked to on her slide around this as well. But, it's not rocket science. This is what we do, every day of our working lives in terms of how we approach sensitive, difficult conversations where people are, telling us things that are hard for them, or we're giving news that's actually hard for us to give them as well. So you need to be kind. You need to be sensitive and mindful of all those other things. You definitely need to be non-judgmental. Don't carry your own beliefs into that situation. It's not about you, it's about them. And you need to be really affirming. So you need to believe them, okay? That's really important. And sometimes people will say that they don't want justice in a legal sense. They don't want the perpetrator to go to prison. They want to be heard and believed. They want what happened to them to be affirmed, for someone to say, I get that must have been awful for you. What a terrible thing to go through. How strong you are to come and tell me and to get some help. And we can do that. They may not want to do any more than that, but that's actually a really easy thing for us to do. You've got to explain confidentiality and your boundaries within that setting, and you can do that well. You can do that so that they don't feel you're going to open the door and run out and tell 20 colleagues, but you can't tell them that you're not going to share it with anyone. You need to find a quiet space, and this can be really difficult in general practice. Often our nurses might knock on the door if there's an emergency in triage or something like that, and it's really hard. So we have got a little message system we can just plug in, and every staff member sees it, that just says, please don't disturb me for 20 if someone can take my next patient. And that just flashes up on everyone's screen so that people know not to walk in. But to have some kind of way of red flagging your practice, look, this is going to take me longer than 10 minutes, and please let my other patients know they might need to come back tomorrow, or can someone else look after them for me? Because it is really hard if you're in the guts of that conversation and someone walks in. That will be a really difficult thing for that person to handle. So you're actually probably better to leave early on and say, hang on, I'm just going to make sure we've got good protected time now, and nobody's going to walk in and go and say to a colleague, this is what's happening. Know who to talk to, and that is all around things like your health pathways and your local processes and your local resources. You've got to know who in your region deals with this all the time. Who can you pick up the phone to and say, this is what has happened. I hardly ever see this. I'm happy to deal with it now and when this person's in front of me, but what do I do in the next half hour? What needs to happen in the next week or 2 weeks or 3 weeks, whatever it is? And they will be able to advise you. And honestly, I think most people who do this work are really open to being phoned at any time. You're not going to be seeing these people at 3 a.m, which is when we usually get called by the police. So if you're ringing them at 4 o'clock on a workday for some advice, I don't think anyone is ever going to begrudge you that. So don't be scared of picking up the phone. Know your local referral processes. Around the country, the ages that different services see people will differ. So in Wellington, our adult and adolescent service sees people from 14 years upwards, and 13 and under goes through the paediatricians at the hospital. In Auckland, they have a super complex system where it's a certain time of day is this age, and night time it seems very... I don't understand the Auckland one, I don't know what it is in Cambridge, but it differs around the country, so you've got to know who to phone for what particular age range. Call the support agency as well. So we've got help coming this afternoon, but find out who that is in your area. Is it rape crisis? Is it victim support? Is it help? And get them in to talk to your practice. It's actually a really helpful way to kind of put faces to names. So you could recreate the panel we've got today in your service and actually get to know the people, so that when you are picking up the phone to refuge or help, you kind of know what you're going to be able to expect on the end of the phone. If it's acute sexual assault, the second bit's actually more important about this, but preserve forensic evidence where possible. But actually the bottom line is, provide medical care if it's needed. Therapeutic care is more important than forensic stuff. So if someone is there and you are in an after-hours centre or working in ED and they have got reasonably significant genital bleeding and could have an injury from this, you don't do nothing. You treat them exactly as you would normally. You make sure they're hemodynamically stable, you get them examined, check for injuries. You might want to ring the sexual assault service as well and get them alongside you, but you have to look after the patient first and foremost. If there are no acute medical needs, ideally do nothing in terms of examination, because anything you do can alter the findings in terms of the DNA. So if, for example, someone comes in and you've already put a speculum in and taken swabs and had a look, we really can't get a lot in terms of forensic samples from that. So ideally kind of think, okay, if they don't have acute medical needs, there's no concern about injuries, that side of it we can kind of sit and wait on. Don't do any examination unless you need to, but leave that to the sexual assault service. And don't do much other than urgent care until you speak to someone on call. So if they're medically stable, ring up first before you do anything further. In terms of other things that you can do to try and preserve forensics, ideally don't give them anything to eat or drink, because again, if there's oral stuff happening, they could lose that. And unless they're desperate to go to the bathroom, probably advise them not to, because again, wiping can get rid of a lot of the DNA in the genital area as well. So try if you can to do that, but don't worry too much about that. So how are you going to have this conversation where you work? And I was going to get you through this in wee groups, but I actually think we probably haven't got time. So we might just go around the room and think about this. But in your practice or your ED or your midwife service or wherever you work, who are the people that could have this conversation? Who are the people that could ask? What settings could they ask in? Are there situations where it's actually a really easy time to routinely inquire about sexual violence rather than settings where it's deeply inappropriate and you absolutely could never do it? And are there things that you could take from today and go back to your practice and sit down as a group and say, actually, this is something we could do better with a little bit of thought and brainstorming. This is something we could routinely start to ask because we've got these situations that happen in our practice where that could be part of what we do and part of what we build into our processes. And an example is at student health, our nurses tend to do most of the emergency contraception appointments, not all, but they tend to do most of them, and it's a routine question now. Every single time we do emergency contraception, they have to ask, they have to routinely inquire about sexual violence. And I was just telling someone earlier, we would get about 5 or 6 a week just from that questioning at emergency contraception appointments. So those are ones that we wouldn't have had. They're not coming in about that, they're not necessarily wanting help or support about that, but when you ask, that's something that's happened. And then they know that you are a service that they can come to for that. So thinking about how you could do it better. One thing I read in one of those UK newspapers not that long ago was a little trial they'd done over there, and I don't know whether it's gone on to be common practice, but I thought it was really clever, and one day when I've got time I'll explore it a bit more. But they had a thing, they got all their patients, they wanted urine samples on to go to the bathroom, and there was a little note that said, if there's something you want to talk to us about in confidence, please put a yellow sticky on the bottom of your urine sample. And they had these little yellow dots, and so they stuck it underneath if they needed to, handed it back to the nurse or doctor, and it sat there to be checked. And then when it was dipstick, they'd go, okay, I either need to get him out of the room now to have a conversation, or I need to try and find a way to contact them later on. So it was a very surreptitious way of saying, give us a little red flag if there's something that's going on for you.